Welcome, welcome to the CGSP's speaker series. We have a really exciting talk today by Professor Hui Zheng, presenting immigrants' mental health dilemmas. And I should start by saying, by the way, my name is Ito Pen, and I'm the director of the Center for Global Social Policy. And I have the privilege of chairing this talk. Welcome. By the way, but before I go on to introduce Professor Zheng, I would like to make a land acknowledgement statement. So I'll just read this. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississauga of the Credit. Today, this meeting place is still the home to many Indigenous people from across the Turtle Island, and we are grateful to have the opportunity to work on this land. Now, I know, although land acknowledgement statement might sound kind of superficial and performative, but I think it is really important to recognize and remind ourselves of the fact that we are all settlers here, and that we share this place with many people and living beings as Indigenous people and many animals and plants have shared this land with us. So the acknowledgement is, in a way, an expression of gratitude and appreciation to those whose territory we work and live on, and a way of honoring the Indigenous people and all the living beings who have been living and working on this land from time immemorial. So with that, let me introduce you to Hui Zheng. Hui Zheng is a professor in our department, Department of Sociology, here at the University of Toronto. He's a demographer, social epidemiologist, and quantitative social scientist. His research focuses on understanding the causes, heterogeneity, inequality, and trends in population health and aging, and on developing statistical and I lost my reading. Okay, let me start. What was I? Statistical and demographic methods, right, to integrate the sociological, demographic, and epidemiological and biological utility of various theories and conceptualization of health and mortality. That's a mouthful. Okay, he has studied the impacts of social structures and institutions such as income inequality, medical expansion, work environment, and the marriage market on health outcomes, trends in health disparities, heterogeneity in aging and mortality, the life course effects of obesity, and the roles of selection in health production and aging. His current research project addresses rising health challenges in the US. I hope you do Canada as well. And nativity disparities in labor market outcomes, aging, and health. Now, his work has been supported by US CDC and NIH, published in leading journals, including American Sociological Review, Demography, American Journal of Epidemiology, Journal of Health and Social Behavior, Social Science and Medicine, and PNAS, and covered by media outlets such as The Time, The New York Times, The Atlantic, US Today, Newsweek, and the times you came. And he has obviously received publication awards from ASA and IPUMS. That's really impressive. I can't wait to hear your talk now. So I say, why don't you take over and give us your talk presentation, maybe about 45 minutes, and then we could break for question and answer. Okay, great. Thank you. Wow. Amazing.
Thank you, Ito, for a very kind introduction. Thank you, everyone, being here. So today I'm actually a bit unaware. So if I talk nonsense, and I have an excuse today. I'm going to present work with my collaborator with you from UCLA. So we start working on immigrant health since the last several years. So in 2025, we published one paper in demography and find out that immigrants increasing depression is one of the reasons why their advantage in disability can diminish cause life costs. Right. So this basically is kind of follow-up study to that paper. Is we try to figure out how immigrants' health really change, how immigrants' mental health really change, and what's the mechanism shaping immigrants' mental health dilemma in later life. So many social science research have documented that immigrants have better health, better physical health, including lower mortality rate and lower rate of cardiovascular disease, heart disease compared to the native born population, and we call it immigrant health advantages. Right? And this health advantage has been attributed to several factors. The first is about selection. That is, healthy people are more likely to migrate in the first place. The second is immigrants' better health behaviors like lower rate of smoking, which can also promote immigrant health. And the third reason is immigrants tend to have tighter social network and community, and that can also be protective of their health as well. So for the same reason, right, and we may also think immigrants may have better mental health as well. But indeed, many US-based research find that immigrants have a better psychological stress and a better mental health and seek medical treatment for anxiety and mood disorder less frequently compared to a native-born population. Right. So in other words, there is some evidence that immigrants do have better mental health. And but we don't really know like how this mental health advantage may really change. Do they still maintain this mental health advantage in later life? And if it's not, then why? What's the reason? So in theory, right, under this mental health advantage can grow as immigrants become more adapted to the destination country, including Canada and the US and so on. Because in the beginning of arrival, they used to face this so-called acculturative stress, like language barriers, cultural conflict, and so on. But over time, this improving English proficiency and cultural immersion can be protective, right? Can potentially lead to better mental health in later life. But on the other hand, immigrants also can experience this cumulative exposure to discrimination and other inferior work environment. And that may play a toll in their health and may potentially erode their mental health advantage in the later life. So literature on focus on immigrants, older immigrants actually also find that older immigrants are more likely to have mental health problems compared to the native-born population. But most of this research is based on cross-sectional analysis. So we don't really have this longitudinal data for people over life course to see how their mental health really change. So we don't really know how immigrants' mental health advantage compared to native-born population really change across life course. So that's why today's study, I'm going to present a longitudinal study to see how immigrants' mental health advantage really change and what may contribute to these changes in over life course. So I'm first going to present kind of conceptual framework to think about how depression really change. Right. So what's the life course pattern of depression and why it happens a certain way. And then I'm going to use this conceptual framework to understand what pre-migration and post-migration factors may potentially shape nativity gap in mental health across life course. And after that, I'm going to talk about the data, the results, and the implication of these results on this immigrant mental health dilemma. So first, life course pattern depression. So very prominent mental health scholars, Malowski and Ross, and who actually used to be in my prior institution, Ohio State University. And so they proposed these three theses to understand how depression really changed across life course. So the first thesis is called age as a life cycle. That argues that depression can decrease from early adulthood to this mid-adulthood as individuals start entering marriage, establish careers, and experience this increase in the personal earnings and household income. But once they transition to retirement and experience widowhood and reduce income and earnings in later life, then depression level can really increase, of course. And aging is also related to many loss-related events, like loss of friendship, loss of family members, and the loss of social network support, and the decreased social integration in later life. That can all elevate the depression risk in later life. Right, so in other words, this age as life cycle thesis argues that the life course pattern depression, this life transition of economic, marriage, and the employment status can create this mirror image of depression. That depression first decrease and then rise in later life. And the second thesis is called the age as decline thesis. This this argues that depression can really increase from early adulthood to later life due to this accumulation of disease and illness. Right, so disease illness are main stressors for depression, especially in later life. Right, so when disease illness increase in later life, that then can increase this depression risk in later life. And the third thesis is called age as a maturity. That is in contrast to think about depression as a result of physical health decline. Age as a maturity thinks that depression of aging is actually can foster this greater insight and greater skills and self-esteem and mastery. And these are very important psychosocial kind of skills we can use to elevate mental well-being. So that's why based on this age of maturity hypothesis or thesis, depression can actually decrease across life course. Right? So these three theses actually propose kind of different life course pattern depression. So much literature actually finds this U-shaped pattern depression. So the evidence here is relatively old from Illinois in 1985 and the US in 1990. And but overall, they find this depression for this U-shape. That is, middle-aged adults have lower level of depression compared to young adults and compared to the older adults. Right. So this is kind of consistent with this age as life cycle thesis. But age of decline and the age of maturity can still work simultaneously, with age of maturity being more predominant in the beginning of this adulthood, in the early adulthood to middle adulthood, and the age has declined to be more dominant in later life. Then the countervailing influence of these two processes can also generate this U-shaped pattern of depression, right? So no matter which thesis is, no matter where the thesis work in tandem or not, they all suggest that different social groups may experience different mental health trajectory due to the different timing and the extent of change in life events and health decline. Right, so that's why in our study, we're trying to understand how immigrants and natives may experience different life events over life course and generate different kind of mental health trajectories. So literature generally find immigrants have bad mental health, like they report few symptoms of mental illness and better psychological well-being than natives. But when the research shifted to older population, they find this finding flip. That is, older immigrants have higher preference of mental health problems and are more likely to report depression in later age compared to immigrants. So reversal of immigrants' relative psychological advantage across age then imply that immigrants may potentially experience this more rapid increased depression in later life compared to native population. That can lead to this convergence or even crossover or reversal of immigrants' mental health advantage in later life. So as I just said, less much kind of limitation in the prior literature, including my own study in 2025. It's based on cross-sectional data. But so basically, we compare immigrants, natives across different age group, but they are different people. So we don't really know how immigrant health really change within individual level. And some study may also only look at very narrow age group, like VMOs and trans study only focus on age 51 to 63. So we don't really know how this life course pattern may look like. And other studies may use this very short longitudinal data and use age migration to infer this life course process. So what I mean here is that they compare immigrants across different age and migration group and to find immigrants who migrate to US or Canada. But in early age, they tend to report more mental health problems compared to immigrants who migrate in later life, right? And they infer this lifelong process from this age at migration comparison. But we know that immigrants migrating at different age may be selected differently. So who are migrating in the early age may be less selected health-wise compared to who migrate in a later life, because child migrants tend to be brought to the US and Canada by their parents. So they're less selected compared to adult migrants. So in other words, it's kind of misleading to infer this lifelong experience by comparing immigrants across different age and migration groups. And our studies may also only focus on Hispanic immigrants, right? So my study today is actually kind of focused on US, right? But hopefully the finding can have implication in Canada as well. So some study also only focus on Hispanic immigrants or combined immigrants, regardless of land, race, ethnicity. So we don't know how this kind of a nativity gap in impression over life course may differ by different race ethnicities. But despite this limitation, much literature do suggest that immigrants may potentially have more mental health problems in later life. So we should experience this immigrant mental health advantage really diminish across life course. Then the question is why? So we look at many factors through childhood to later life. So including these pre-migration factors, including their kind of experience in the country origin in childhood, and the post-migration factors. That is their encounters in the US or maybe in Canada, depends on context we talk about. So we look at how these pre-migration and post-migration factors may jointly contribute to these immigrants diminishing mental health advantages. And in terms of pre-migration factors, like so some research, including Black's not here, but Black study, like, so he found that these immigrants who are exposed to this armed conflict are more likely to report depression later life. All immigrants who flee this political violence in their home countries may endure this lifetime kind of trauma, right, even before arriving in the US. And many studies also find that this childhood abuse, no matter physical or mental abuse, can potentially lead to this reduction in perceived social support and greater strengths in the relationship with families and friends, and also lower level social integration in later life. So this childhood abuse can potentially also diminish these immigrants' mental health advantage in later life. And since most immigrants come from less developed countries, which has relatively higher mortality rate compared to US or Canada, then immigrants may potentially face more this kind of family instability, including parental death in childhood. And this family instability can potentially also either influence health or mental health directly, or may reduce their health-related social economic resources in adulthood. And our study also suggests this quality of parental care and financial hardship in childhood can also play a toll in individuals' mental well-being in later life. So immigrants may potentially face more kind of high level of inequality and poverty in their country origin that can carry through their life course even after they arrive in the US. So then the question is, if immigrants face more this kind of childhood adversities, why they have better mental health in early adulthood, right? So our hypothesis is that it still is kind of related to selection. So that is, the immigrant still is more possibly selected in terms of health and in terms of this psychological strength. So they're able to suppress or postpone the negative consequence of these early life adversities on their psychological well-being until later age, when they begin to experience these age-related trends. Right, so these early life adversities were postponed to later age and then increase immigrants' risk of depression in later life, diminish their kind of mental health advantage throughout the life course. And in terms of post-migration factors, as I said, when immigrants come to the country of destination, they face this so-called acculturative stress, right, including language barriers, cultural conflict, financial constraint, and so on. But so some dimension of this acculturative stress can improve over time, including this improving like English proficiency and cultural immersion. So, but other dimensions like acculturative stress can actually increase. For example, discrimination, right? So, immigrants upon arrival, kind of paradoxically, immigrants may report low level depression compared to their native co-ethnics, because race-based discrimination is a relatively new thing for immigrants. They don't experience this race-based discrimination in their home country. So once they come to the States, come to Canada, they experience race-based discrimination, new thing. So they do not realize this very subtle discrimination in the beginning. So they perceive a low-level discrimination in the beginning, and they may also less likely to expose to people outside their race ethnic group. That's why they may also report low level depression upon arrival. But when this length of stay increase, their experience of discrimination may become more and more similar to their native co-ethnics. And the second is that even though immigrants have very strong ties, right, has very strong community, but the longer they stay in the US or Canada, become harder for them to maintain very strong ties with their families, friends, and the community in their country of origin. So in other words, this may potentially increase their sense of lack of social support and the sense of social isolation. And this acculturative stress may also play a toll in their family cohesion support, right? So even though they have higher level of family cohesion support in the beginning of immigration, but this psychological stress may potentially weaken their own family cohesion and support as well. The third is something that we really emphasize in this study is about transition to retirement. So transitional retirement usually kind of can lead to this loss of social network, social support, and also the loss of purpose, sense of purpose, purpose of living, right? And so not all retirees are vulnerable to retirement in the same degree, right? So not all retirees are susceptible to loss of sense of purpose in the same degree. But for immigrants who migrate for work, migrate primarily for work, then traditional retirement will especially hurt their sense of purpose, sense of purpose of living, and then reduce their social network, and that can have this kind of very kind of large negative consequence on their kind of psychological well-being. And the fourth is that immigrants may potentially face more kind of financial insecurity in later life. So some work like live here and did in social forces live here present work about how this net gap in this wealth gap, net gap in wealth actually can become widened in later life due to this lower rate of wealth accumulation among immigrants compared to the natives, and also due to this ongoing kind of remittance application to their home countries that also can widen this immigrants and natives gap in wealth in later life. And then this combined with this retirement effect, right? Because once immigrants transition to retirement, they lost this very stable wage income. It compounded with this lower rate of wealth accumulation, then immigrants may potentially face more financial insecurity in later life. That can also increase their risk of depression in later life. And the low wealth accumulation can also compel immigrants to settle down in a relative in neighborhood with low level quality, including like neighborhood disorder and the neighborhood alienation. So, and the study also found immigrants have lower rate of home ownership, right? So then post-retirement, they may boom due to this wealth and also due to this lower rate of wealth accumulation, they may be more likely to experience this downward mobility in neighborhood quality, but that can also have a toll on their mental well-being later life. So discrimination, social support erosion, transition retirement, financial insecurity, and neighborhood disadvantage is informed by this kind of age life cycle thesis I just talked about. So immigrants may experience different life events and the declines in the advantage in the certain events at larger degree compared to native population that then lead to a faster increase in the depression later life. And lastly, is that immigrants' physical health advantage may decline with age, right? And according to HSD decline thesis, right, accumulation disease illness are a main stressor for psychological well-being later life. So if immigrants' physical health advantage decline with age, then the mental health advantage may also decline due to this because this mobility and disease are main stressor of depression in later life. So our study is going to kind of look at this pre-migration and the post-migration factors simultaneously to look at what really matters for immigrants' psychological well-being and mental life. So we use data from US health retirement study from 1992 to 2020. So it's a longitudinal data, and it has 15 waves, and so it has good amount of immigrants and also foreign and the native population include about like 32,000 natives. And because we shape data in person year format, and so it has about like 176,000 person years, and about 4,900 immigrants, and about 23,000 person years. And the age range is from 51 to 84 in hours. We track immigrants and also natives well-being through these 33 years. And the main outcome in our study is depression. So depression is based on this CSD scale. So it basically asks respondents, do you feel depressed, restless, lonely, sad, unhappy, everything was effort, couldn't get going, do not enjoy the life, and so on. And so each measure is binary measure, right? So CSD is basically is competition of this 8 binary measure, and it ranges from 0 to 8, with higher value indicate towards depression. And we also design kind of sensitivity analysis by bringing down the scale by using a cut point of 3. CSD more than 3 means depression. And in the analysis, like the main analytical approach, we use a pool OS with this within person correlation collection. And we also try this multi-level growth curve model. And but multi-level growth curve model has higher, kind of more stricter kind of exogenous assumption compared to pool OS. That's why I present the finding from pool OS in the main manuscript, but I can talk about the findings for multi-level growth curve model later on as well. So in order to see how this immigrants' mental health advantage change with age, we create interaction between age and the nativity. And we also create interaction between age square and the nativity. But because age square and nativity interaction is not Simpson, so that's why in our main presentation, I'm just going to show you the interaction between linear age and the nativity. And we also stratify by analysis by race, ethnicity, gender to see where this kind of pattern may be universal across these different social demographic group now. And in terms of mediation analysis, we basically add a mediator to the model to see how much they can explain this age nativity interaction coefficient. And as I just said, we include many kind of mediators to see what which really matter, including childhood condition like early life trauma, family arrangement, instability, and parental wealth, childhood financial situation. And due to time constraint, not go into details about how we measure this, but I can explain more about how we measure these variables in the Q&A session. And in terms of psychosocial and the social economic, is time varying, including lifetime stressful events, daily discrimination, social support quality from 4 dimensions, including spouse, children, family, and friends. And we also look at marital status and number of marriage, work status. as I said, work status or transition environment, retirement is one factor we especially can focus on, and also house wealth quartile. In terms of neighborhood, we look at neighborhood physical disorder and also neighborhood social alienation, including how much you trust your neighbors and how much do you feel like you belong to this neighborhood and so on. And in terms of physical health, we have four kind of measures. One is mobility history, one is a current chronic condition, and then it's two measures of disability, including functional limitation and activity limitation. Right, so we look at different measurement of physical health to see how the funding may differ by different variables. So far, so good. Right, so now let's kind of look at the main results here. So this figure shows the age pattern of depression from age 50 to 84, and the dotted line here is US born, and the solid line is foreign born. Or in our solid line is immigrants. But so similar to this age of as life cycle thesis, right? We do find this depression for this U shape. That is, immigrants have lower level of depression compared to the native born population in the early 50s, but that depression declined at a slower rate compared to the natives. By around age 65, then depression started increasing. So in other words, this indicates this transition to retirement really play a very important role in how immigrants' depression increase in later life. And in contrast, for natives, their depression continued to decline until around age 73 and increase outwards. Right? And around age 66, we find immigrants start having more depression, high-level depression compared to natives, and this gap kind of increased, even widen in later life. And if we look at this nativity gap in CES, right, you'll find this nativity gap. Also, immigrants have, this is just another way to kind of interpret figure I just show you. Let's say immigrants have lower level of CSD in the early 50s, and by around age 66, they start having higher level CSD compared to natives. And by around age 73, and you find there's no kind of intercept between this confidence interval and zero, means that by around age 73, immigrants start having this so-called statistical symptoms, higher level depression compared to native born population. So in other words, we do find this very strong evidence that immigrants' mental health advantages really diminish and reverse in the later life. And we also look at how this pattern may differ by different CSD items. So as I said earlier, like CSD include 8 items, right? And immigrants, again, the solid line here is immigrants, and the dotted line is natives. Immigrants are more likely to say they feel depressed and feel unhappy, feel lonely, and feel sad, and did not enjoy life. Most in this older age group. And even though they are less likely to report everything was effort, sleep was restless, could not get going throughout most in this older age group, nonetheless, in some situations, we do find immigrants advantage in this either completely disappear in older life. Right. So in our overall, the CSD composite or CSD scale finding is consistent with this kind of respective CSD item finding. And we look at how this trajectory or pattern may also differ by different race, ethnicity, gender, by comparing immigrants to natives within every kind of race, ethnicity, gender. So the bottom row is woman, and the top row is man. And among women, white female immigrant and Hispanic female immigrant especially has more pronounced increase in depression compared to their native born population. And their kind of male counterpart also have this increase in depression compared to their native born counterpart, but this onset of crossover tend to happen in later age compared to their female counterpart. And among black men, like the point of this crossover happened around like 73, out of 73 immigrants, black male immigrants having a higher level of depression compared to their native born counterpart. And the black female immigrant is the only exception here. That is, they have low level depression throughout all this age group, even though this advantage can slightly diminish in later life. And for the other group, so his HIS does not have Asian category, right? It has this other category, but it should be predominantly Asian here. But so its sample size is much smaller compared to our group. That's why the left course pattern is not a U shape, instead of it's a reverse U shape. We think this probably is mainly due to this smaller sample size problem. But despite this different kind of shape of this depression, but immigrants' mental health advantage still decline or still completely diminish or disappear in later life compared to their native-born counterparts. Right. So in other words, overall, we do find this immigrants' diminished mental health advantage is observed across most of the social demographic group. And we also create interaction between age, nativity, and race ethnicity, and age, nativity, gender, and these three-way interaction actually are not concerned. In other words, this even though we do find this even though there's a difference in timing and a gap, even though there's difference in the timing of this crossover in the mental health between immigrants natives, but overall, this diminished immigrants' mental health advantage across life course is kind of universal across this race, ethnicity, and gender group. That's why in our mediation analysis, we're just going to compare immigrants to natives without further distinguish race, ethnicity to preserve the statistical power. But in our sensitive analysis, we do break down the analysis by different race, breakdown by Hispanic and non-Hispanic. But we cannot further break down by race ethnicity within non-Hispanic due to very small sample size here. So, so first let's look at how this childhood environment may potentially contribute to immigrants' faster increase in CSD with age. So we look at four kind of childhood factors, including childhood trauma, parental wealth, parental warmth, and the childhood family arrangement, and childhood financial situation. So for each factor here, we have two models, like baseline model, basically just regress CSD on nativity, interaction between nativity and age, adjust for age square, and race, ethnicity, gender, and birth cohort, and so on. And in the model two, we add this mediator into model, right, to see how much they can explain this interaction coefficient in the first model, right? So since immigrants lose this mental health advantage in later life, right? So then the interaction between foreign-born and age should be positive, because at age 51, right, the coefficient here is negative, means that immigrants have low-level depression, right? So if their depression advantage diminishes with age, then the interaction should be positive, right? Then if a mediator explains this immigrants can fastly increase in CSD, then it should reduce this interaction coefficient and result in this negative percentage increase. So for childhood trauma, we do, and the parental warmth, we do find they reduce this interaction coefficient to some extent, but that the interaction itself is not significant in model one, right? So that's why we do not have very kind of solid evidence that this childhood trauma and parental warmth can explain immigrants' increasing mental health disadvantages in later life. And the childhood family arrangement and the child financial situation, they do not explain this interaction coefficient at all because they are positive. Right. So in other words, for these four observed childhood factors, we do not find very solid evidence that immigrants' increasing CSD is due to these childhood adversities. And then we look at these post-migration factors, right? So many of these post-migration factors are time varying. And thus, this figure shows how these mediators change with age and how this differ by immigrants and natives. Again, immigrants are solid line and natives are dotted line. So similar to what I said before, immigrants are actually less likely to report discrimination in the beginning because they come from this their home country does not have this race-based discrimination. So race-based discrimination is very new for immigrants, and so they have very lower level depression, a very level low level of discrimination compared to natives, but this difference completely disappeared in later life. And the immigrants report less likely to report a lack of social support in the early 50s, but more likely to report lack of social support in later life. Now, was compared to natives, they actually face more disadvantage in social support in later life. And in terms of neighborhood disorder, immigrants report lower level neighborhood disorder in early 50s, but this gap completely disappeared in around age 85. And the more interesting thing is that immigrants face more neighborhood alienation in later life. So for natives, they report lower level of neighborhood alienation in later life from age 50 to 84, but the immigrants have a very different pattern. They report more neighborhood alienation in later life. And the immigrants are also more likely to be employed and more likely to be married, but this advantage completely disappear in later life. Okay, so the native gap in employment status and marital status completely disappear in later life. And another thing that's kind of similar to neighborhood alienation is that immigrants actually they are more likely to fall into this bottom left quartile in later age. Very different pattern compared to the native born population. Right. So in the 50s, they actually less likely to be in this bottom left quartile, but in later life, this likelihood can increase and widen gap between immigrants and natives. And immigrants also report low level chronic condition compared to natives, and this gap kind of slightly decrease in later life. So now I'm going to kind of shift gear to understand how these kind of post-migration factors can contribute to immigrants' faster increase in depression in later life. So in each factor, I'm still going to present coefficient from the model without controlling for mediator and the model including the mediator. Right? So we focus on interaction between foreign born and the age. And so if mediator account for this faster increase, they should reduce this interaction coefficient. We find lifetime stressful events have zero contribution here, but discrimination can account for like 29% of the immigrants kind of faster increase in depression in later life. Lack of social support, mental status can account for now 13%, and neighborhood physical disorder and social alienation can account for now 13 and 19%. So in other words, this kind of post-migration factor do play a very important role in increasing immigrants CSD in later life. Now, I want to focus on work, right, and transition to retirement. That is how work really influences immigrants increasing CSD in later life. And in model one is just basic model, right? And this positive coefficient means that immigrants experience a faster increase in depression. And in model two, we include employment status, and employment status is negative related to depression. It can reduce depression, but contribution from this. So I flip the sign here, right? So, but contribution for employment to the reduction of this interaction coefficient just about 6%. So it's not big contribution. But in model three, we include interaction between employment status and the nativity, and find immigrants especially benefit from employment status. So employment can reduce depression by about 0.82 units for natives, but by about 0.98 units for immigrants. So in other words, immigrants benefit more from employment for their psychological well-being. So once they transition to retirement, they are going to hit by retirement harder compared to native born population. And so once we account for the interaction, then this can account for 40% of this faster increase in CSD among immigrants compared to natives. And then we kind of try to understand why, right? Why immigrants are hit harder by joblessness or transition to retirement compared to natives. We look at education and wealth quartile and find that once we control for education and wealth quartile, the interaction no longer significant. In other words, it means that the reason why immigrants hit by joblessness harder is because they have on average, they have lower level education, which can restrict their non-job related resources out of retirement. And they also have low level of wealth accumulation, right? So they are more likely to fall into this bottom wealth quartile auto retirement. So education, the wealth kind of is completely explain why immigrants hit by jobless harder compared to the native born population. But including the model 5 include interaction between SES and activity, and but including education and the wealth does not fully explain why immigrants have faster increased CSD beyond what work has already done in Model 3. Right? So in other words, SES and can explain why immigrants hit by jobless harder, but it does not really explain why immigrants have a faster increase in depression once job is included, once work status is included in model. So this then we kind of last thing we try to test is where this kind of faster increase depression is related to immigrants' kind of erosion of physical health advantages. So model 2, model 3 include current mobility status and mobility history, and we find this mobility is partly correlated with CSD, but including them does not really explain why immigrants have a faster increase in CSD. And the model 4 and 5 include two measures of limitation or disability, including functional limitation and activity limitation, including them does reduce this introduction coefficient. And disability is kind of correlated with a higher CSD level. But we caution this finding for two reasons. The first is that depression is, in this disablement process framework, depression is usually treated as a precursor to disability. The second is that marginal reduction in interaction coefficient is due to the inclusion of activity limitation. Activity limitation is measure of ADL or IADL. It's a more severe form of disability. The onset of activity limitation tend to happen in quite late age, also age 70, right? But the onset of erosion in immigrants' mental health advantage is far before the onset of activity limitation. So we think the causality is more like from increasing depression leads to later life disability rather than the vice versa. So then in the final table, we kind of put together all these kind of important factors we identified in the prior analysis, including discrimination, social support, marital status, work, and labor factor in the final model, which then resulted in a smaller sample size. But the overall finding kind of consistent from what I said before, that is discrimination, social support, marital status, work status, and neighborhood environment can account for by 27, 13, 14, and 20% of this faster increase in depression. And all these factors in total can account for about 80% of immigrants' faster increase in depression in later life compared to native born population. And then once we account for all these mediators, important mediators, we find immigrants' natives CSD trajectory become much more similar compared to the one without adjust for the mediators, which I showed you earlier. So once we account for this mediator, immigrants and native become much more similar in the CSD level. And even though immigrants still have slightly higher level depression in later life, but it's not significant because when you look at this native gap in CSD, right? Once we account for the mediators, then this immigrants no longer experience significant increase in depression in later life. And they also no longer experience higher level depression in later life compared to native born population. In other words, the factor we found to account much of these immigrants faster increased depression in later life. And then we did a bunch of robustness check and sensitivity analysis. I'm going to skip this slide, but we can come back to this slide if you are interested to know what additional analysis we did to make sure our findings make sense. So in the end, in conclusion, is overall we do not find sufficient support that this increasing depression in later life among immigrants is due to these early life adversities in their home countries. Instead, much of this experience advantage, reversal advantage, is due to the experience in the US, right? So it's kind of consistent with this age of life cycle thesis. Like, so basically, immigrants are more likely to experience this enhanced vulnerability to joblessness and transition to retirement, and the experience of discrimination, and the reduction in social support, and the rise in this neighborhood alienation and the physical disorder. So much of this diminished advantage is due to the experience after moving to the States. And we also find immigrants, this a steeper increase in depression in later life is not directly linked to the physical health declines, because we find that and in our 2025 paper, we actually argues that the reason why immigrants' physical health advantage decline compared to native population is mainly due to the postponement or the onset of this chronic condition to later life, due to this healthy migrant effect, due to this superior health endowment before migration. But the declines in mental health advantage is not related to decline in physical health advantage. Instead, decline in mental health advantage is more likely to related to that human experience after moving to States. So in other words, it means that these two kind of physical health, mental health can actually reflect different mechanisms, right, contributing to that decline in these advantages. So lastly, I want to kind of emphasize the implication of this study on disability. So in our 2025 study, we argue that this increasing depression is one of the reasons why immigrants advance disability decline in age, in old age. Then they pay more attention and prioritizing treatment on immigrants' mental health depression problem can also reduce that disability in later life. And that is kind of physical health advantage may potentially be by focus on understanding immigrants' mental health problem later life. Okay, so that's all. Thank you very much.
Great. Thank you very much, Hui, for this really interesting presentation. So I would like to break for question and answers period. Do people have any questions, comments, thoughts? Yes. Yeah.
I have a question about the ethnicity of the population and how you, how you found the participants, and also like what kinds of, just a little bit more about the participants that you found.
The data was not collected by me. So data was collected by University of Michigan. So they collect this HRS data and from 1992, right? So it's a national kind of it's a national representative data, right? So they have this kind of national sample frame first, right? So they start interviewing people at age 55 and then track them over time, right? So in terms of race ethnicity, because they have this sampling frame including different race ethnicities, so they are able to kind of get people with a different race ethnicity. But we do not collect data ourselves.
Yeah.
I just want to introduce myself.
Could you mention your name and then...
Yeah, that's what I was going to do. Yeah. So my name is Emily LaRue Rutledge. I'm a visiting scholar in Canada. I'm actually a professor in the UK. I'm originally from Toronto, and I'm here for a year on sabbatical visiting the Center for Refugee Studies. And I also study immigrant mental health and mental health migration. And I wanted to ask you two questions in particular that occurred to me in the talk. The first was, and forgive me because you've done a huge amount of work here, and this is a great presentation, but my first was just a question around the measure of mental health. Yeah. And the question around that is, you talked about people reporting lower levels of depression, and one of the measures in particular that looked like it was quite different was felt depressed. Now, I'm sure you know, and you've possibly considered that conceptions of mental health and thinking around mental health really vary across cultures. And we have a very kind of Western conception of mental health here. And people from other cultures are often very, very reluctant to disclose mental health issues. So could there not be an effect where the longer time you spend in a culture that views mental health in a particular way and talks about mental health in a particular way, the greater the destigmatization towards disclosure of mental health issues, and that in effect could be affecting the appearance of an increase in depression amongst people who have migrated. And actually, it's just a greater willingness to discuss and disclose mental health issues the longer you're in a culture that encourages that. Maybe you can answer that one, and then I have
so I think for this severity self-reporting measure, we always have this problem. Like,
Yeah.
so how much is reflecting the kind of true kind of
Yeah,
underlying depression problem, or how much is just due to reporting bias?
you're right.
Right. So for first, let me talk about CSD measure itself. Like, so it's so in HRS, it has kind of short version of CSD measure. Usually it's like 26 items, right? And so less than study in the HRS by HRS team, they actually compare this short version to this longer version and find they are very consistent, very stable. And for this longer version of the CSD, let's ask and study to kind of to see how this is predictive of mental disorder, right? Kind of diagnosed by doctors, and they find this a high consistency between this CSD measure and the true mental disorder in the population, right? So, but regarding this nativity difference, this is hard to argue. Like, where is it? It's really kind of immigrants become more kind of Americanized.
Yeah.
Then they kind of start thinking about they have depressed.
Yeah.
We think it's yeah, this is a difficult question to answer. We do look at how we do try to see how this may be related to healthcare system, but we kind of control for health insurance, healthcare assessment model. It doesn't really change the pattern.
Well, the access would have the same pattern because
Right.
there would be a reluctant to seek.
Right. So let's is actually in our paper we argue this is actually the reason why we use CSD instead of use this
Who does
doctor
that?
diagnosis,
Yeah.
because immigrants may be less likely to kind of see the doctor even when they have depression.
Yeah.
Right. And then maybe also because health insurance problem, they're less likely to seek medical treatment for mood or anxiety disorder. Right. So using this more objective measure actually may be worse compared to this severity measure.
Agree.
Right. So, but in terms of where immigrants culturally will adopt this kind of depression into their kind of ideology and see more depression as a problem, this question is really hard.
I mean, it's just interesting because when I looked at the 8 measures, like I noticed on sort of things that you wouldn't necessarily associate with a mental health issue, like I think like I have trouble getting going, that wouldn't necessarily be a stigmatized thing to say, oh, I have trouble getting going, but it was like, I feel depressed. There was more of a notable gap in I feel depressed, which would be more of a like articulation of a mental health issue in a Western conceptualization than some of the other ones.
Yeah. So I think the one thing, we use this is so CSD measure scale is kind of well established in the sociology.
Yeah, I know.
Right. So I think we can try to remove the cannot get going from this index to see how this finding may look like. Yeah.
Well, I mean, I know I'm not saying, I think that's still a good measure. I'm just noticing that it's like on things like feeling depressed and was unhappy, those are more kind of statements that are articulating a state of mind that is like, my mental health is not well, whereas restless sleep or like, not enjoying life versus restless sleep, not getting going, they're sort of less, they could be less stigmatized statements, I guess what I mean, than saying that you were feeling depressed or feeling unhappy or not enjoying life. I'm not saying there's anything you could have done about this. I'm just putting it out there as a challenge with the kind
you need some measurement. Makes sense. I think so. So as I said, CSD is well established in sociology. So I think potentially you can just try to, but no matter which measure, like we do find these immigrants start experience these more kind of problems in their life, and in such situation, like everything was effort, and sleep was very restless, couldn't get going. Immigrants still have lower level, but at least kind of advantage can disappear. Maybe focus on more this kind of self-report depression or having maybe is better measure. Is what you said.
So my other question was, is there a way, and I don't know if you have a measure for this, if you captured this in the data, could there be an effect of expectation of old age among immigrant populations versus native born populations? Because the way that in this country and in the US we treat people in old age, and the expectation of care, for example, that they can expect from their sort of children and families here is actually much lower than in many other cultures where people would get old and then be expected to be well cared for and looked after by the next generation, like living in the family home in multi-generational households, potentially with the family sort of doing the caregiving and very embedded in the family. And that expectation obviously could be one that immigrants retain, and then the reality turns out to be quite different, especially if their children are you know, born in the US and adopt the US kind of views about, you know, what you do with your elderly family members. Could that be a factor as well? And have you considered that at all?
So you are saying immigrants may have higher level expectation on the care.
Just very different expectations about the kind of care that they might expect when they reach old age, the kind of like family care they could expect versus the non-immigrant population.
Yeah, so this actually is the first next thing we are going to do is because in the paper we can look at this lack of social support. Right?
Yeah.
We create this kind of summary index.
Yeah.
Right. And actually the next paper we are going to look at is really look at the support qualities by different dimensions. Like so where the expectation of care or support from children may be higher, that may potentially reduce their
But it could also be, it could not be the actual material support. Like, I mean, that may differ, and you may find that the actual support differs. But even if the actual support provided, you know, say by the younger members of the family was the same, in an immigrant population, you could have an expectation of greater familial and social support. But then because they're embedded in the US context, you know, the next generation does. I've lived in many different countries, you know, and in some countries, like it's just people get old, they become very revered in the family. They're in the multi-generational household and they're looked after by the younger generation, like, and that's the way they age. And just, you know, I know from a lot of studies on migration that like those support systems in place to support older family members really break down sometimes when you move into, you know, Canadian or American culture,
and especially if they compare themselves to people in their country.
That's exactly what they could expect in old age, exactly from their family members.
This is a really interesting conversation because I think there have been some Canadian studies about expectations and outcomes in a very different way. Certainly, you know, people like Monica Boyd have sort of done research on sort of the second generation, you know, success of Canadian immigrants, right? It has a lot to do with parental expectation of higher achievement. And as a result, their data show that second generation immigrant children, particularly from Asia, outperform in terms of the sort of education and status and in terms of that outcomes. So, I mean, you know, question about expectations about later life care from children might have something, but I could imagine with on the CD, you know, CASD, I don't know how you can
capture that.
Right.
And it could also just be respect afforded to older people, right? Like, because I would say we live in a culture that doesn't afford more respect with more age, right? Whereas that's not the case in other places.
Yeah. So for this lack of social support is a measure. It asks question like, let me see, if I can find the measurement here. So it's not good. So lack of social support, they ask like where your relationship give you more kind of demand, and where this relationship is stressful or some. It's more than measure. It's kind of perception of this social perception of this quality of social support, right? And but it does not measure. But we don't know where this perception is caused by the higher level expectation, right? So maybe they perceive low level of support because they have higher level expectations. Yes, very good question. Yeah.
Okay.
I just want to ask, is there any consideration of the class of the immigration, such as whether they're refugee, they're under the economic immigration, or they're like just like a family support? Because from my understanding, different like a class of immigration, they have like a different also expectation or their background or I mean, the understanding of their new life here. So I'm just wondering, like, is there any consideration in this respect?
Yeah. Unfortunately, without data, do not have the regime here.
Okay.
So yes.
Oh, okay.
Yeah, but I can can expect refugee will have kind of more mental health problems, or maybe even faster increase depression
Okay.
due to the few resources, including material resources and social support. So.
And my another question is like, because this data collection is 3 decades, I'm just wondering, is there any transfer changes? For example, the immigrant from 1990s compared to the immigrant in 2000 or 2020, those like the period, is there any change?
Yeah, that's very good. I haven't done that. So it possible can do. So the data does include people from different cohort.
Okay.
So we can potentially compare this depression across different cohort. But then the question is a baby boomer cohort that we probably can only locate like early age, like maybe 50 to 60 for the later cohort. But
Okay.
for older cohort, maybe like 70 to 50, 70 to 80. Right? So this kind of very typical kind of age period cohort
Okay.
problem we face, right? But very good common to see how this kind of pattern may differ by period instead of by age.
I would imagine that the different peer group would also indicate different country origin immigrants as
Yeah.
well. So it's not just peer group
Yeah,
in
yeah,
terms
yeah,
of the and entry date, but also in terms
In
of
terms
the
of
race
country,
and ethnicity of the immigrants as well. I think I saw it.
So if you were to like redesign the study, do you think you would focus more on phenotype instead of race? Just because, like a phenotypically white Latino might have more like better chance of like a phenotypically Black Latino and getting a job and facing less discrimination. So like how would like phenotype impact the experiences of these participants, and like would they be facing the same type of discrimination as their native born counterparts? Because like a US Latino group might have that or will have that us mentality as opposed to them and their foreign born counterparts included within that group. Yeah, that's it.
Yeah, very good comment. So we in our study we kind of break down by Hispanic origin and race ethnicity. We do have Hispanic, non-Hispanic white, but we do not look at heterogeneity within Hispanic, right? And I believe Hispanic white, Hispanic black, they have very different kind of integration trajectory in the US. Potentially Hispanic white probably would be more likely regarded as part of the American population compared to Hispanic black. Right? So potentially they can face different kind of pattern. But overall, like we want to emphasize is the pattern here is in terms of timing or crossover, it is different, right, across race ethnicity. But no matter what's the timing or degree of crossover, for most groups, they do experience this decrease in the mental health challenges. But even for the white immigrants, right, for white women, they actually experience a more pronounced increase in depression compared to black women. Right? So phenotype is a factor, but it probably is not the only factor that influences the mental health trajectory. Right? So we were surprised by how non-Hispanic white female immigrant actually have more pronounced increase even compared to black female.
Is the reason why the chart starts from 50 to 85 is it because like depression rates are correlated with age? Or?
It's because our age group is from 51 to 84.
Yeah, no, I was asking why it's from 50 to 84 and not earlier or later.
Because the data is from 51 to 84.
Oh, I see.
Yes.
Just another point on the gender. So again, another thing that we know is that like when it comes to disclosure of mental health issues, women are much more willing and able to disclose, depression and mental health because it's more socially acceptable for females to disclose mental health issues than for men to do so. So again, that may
play a role so I think it may play a role, especially for the black female immigrant, like they the degree increase is not does not lead to this crossover compared to.
Yeah, true.
Yeah.
It wasn't affected the.
Yeah, so that's kind of interesting.
But you do see it in the Hispanic men versus women and the
Exactly.
white men
So
versus women. Yeah.
Yeah, I think gender definitely. I mean, we do find like compared to men, right? And most time,
Yeah.
especially for white women and Hispanic women, they have steeper increase
Yeah.
compared to like
It looks that
gender
they-
male counterpart. But it definitely can play a role. Yeah.
Any other questions?
Yeah. I wonder if there is data out there for international comparison at all.
Yes.
And part of the reason I'm like, on the question of like expectation, I was just also thinking of the American dream. And when you go and you have these huge high expectations and hopes, and then they're like dashed.
Yeah.
So I wondered, yeah, just of all the different, not just Canada, I'm sure there are lots of people come here and their hopes are dashed too. But like, if you're just comparing to with like a whole lot of other immigrant receiving nations, I just wonder.
Yeah. I think Canadian does not have HRS related similar kind of
But-
equivalent data, but UK does. UK
Yeah.
has this increase on joint study, and the European has this shared data that we potentially can use to see where this where we can find some pattern.
Yeah, interesting.
And also depends on different kind of because our study really emphasize this. The first is discrimination, right? The second is transition to retirement. How this
Yeah.
potentially can change this social support and the neighborhood and so on. And I think different countries may have different neighborhood arrangements that can play a role. So
Do you have country of origin data in this data set?
No.
You don't?
no, you don't. It has a race, but it does not have country.
But not a country.
Yeah.
Because I was thinking you could proxy.
Except for Hispanic, I can put further separate by Mexican and non-Mexican. But this is the only thing I can do.
Yeah.
That's instead.
I was just thinking if you could proxy, like if you know, that you could break down cultures all the way from very individualistic to very collectivist. If you had the country of origin data, you could break it down on
Yeah.
that spectrum.
But I guess most white population are more from European, especially from Western European countries.
Any other? Oh, yes, okay.
You could do this exact same experiment on other data sets.
Yeah, I think for the UK and the shared data potentially is doable. But especially UK data, because shared data, I think it's if I remember correctly, it only has like 8 waves. Shared
I
data,
don't know that data set.
5 to 8 waves. Like so, HRS has really a much more kind of longer length of flow out over time when compared to European data.
Did you have a question?
I'm a little curious about like the non-Hispanic Black women. Like, why do you think they're?
Yeah, so we don't have answer here. Because I think Black immigrants are very selected group in the US. Like so maybe contradictory to many people's perception, Black immigrants are very selected. They have the lowest mortality among all the groups, even compared to Asian or Hispanics. So maybe Black female immigrants are even more selective. Like I don't have one answer here. Like but I think selection may play a very important role. Like they probably are more selective in terms of this psychological resilience and potential. But I don't have very kind of. And the other thing I also need to mention is one limitation of this study. Even HRS is great, but immigrant sample size is still not large.
Yes.
Right? So like if we look at this, like we have 4,800, right? But once
You break
about
it down.
50% is Hispanics, right? Another 50% are white, other and black. So maybe a sample size is a reason why we do not find crossover of the Black population. So that's why in our mediation analysis we can combine all of this at least to get together. But we do in our kind of robustness analysis, we do kind of break down by Hispanic background, right? Like here, like, well, it's a Hispanic and non-Hispanic, but overall finding similar, but we cannot further break down non-Hispanic by race ethnicity because sample size is way too small.
Yeah.
Especially when you need to track them over time, then sample size becomes really small with analysis.
Okay, in the last 5 minutes, I want to ask. I hope it's okay for the people. So, the earlier study in Canada also showed, this is studies from 1990s, also showed the decline in the healthy immigrant effects. Now, those studies mainly looked at the physical, right? So physical health and the sort of understanding or interpretation was that because they get acclimatized and follow, after 10 years, they are more likely to lead very similar kind of lifestyle, eating habit, and all these things as the native born Canadians, and therefore they decline. So your study is very unique in that it looks at the mental health, and I don't think there is a similar kind of study in Canada. It will be very interesting to look at the Canadian data. I don't know whether we have the similar kind of data or not, but I'm thinking that compared to American data, Canadian data will be very different because the source countries of Canadian immigrants are so different from Americans. There has been also changes in the sort of cohort, the country of origin, depending on the cohort size, right? And so you could actually do quite a number of different kind of analysis based on cohorts as well as based on the sort of country of origin. So what would you kind of guess in terms of
I think the story will be kind of similar. I think even Canada is probably more diverse, more multicultural, right? And but what we found here is mainly is like retirement, joblessness is one very important factor. I think. Right. So for immigrants coming to Canada, they also, especially Canadian immigration system, kind of different from US. Like US system, like much of this immigration channel is through family unification, and but Canada is mainly for job, right? And so in our community, most immigrants coming to Canada is actually for job. Then I think the finding from this study is actually can apply to them. That is, once they transition to retirement, let me start thinking why they come to Canada. Like once they retire, right? So most of the immigrants still stay in the destination in the end for their family, actually. Right. But it's many of them actually once they retire, they start thinking like why they stay in this country, and especially after retire, because for immigrants, work is the center of their life, right? So most of their social support network is actually through workplace. So once they retire, then it's they suffer from a lot of loss of this social support, right? And also loss of sense of purpose. I think this kind of finding can be resonate with different countries.
Very interesting. Just for the information, so the majority of the immigration sort of admissions to Canada currently now, something like 68% is for economic class. So and they tend to be highly educated, more educated than native born Canadians, right? And only about 28% are sort of family reunification. Whereas in the case of the US immigration, the majority is coming from family reunification. And so very different kinds of sort of socioeconomic and backgrounds and things like that. So interesting.
But if I remember, we actually also break down by education. But I did not present here is we actually look by education without anything. Yeah, we break down education without further break down by gender. So for example, for every different every race group, right? Oh, I did not have figure here. Every race group we also break down education. We do find even for higher educated group, we observe this crossover as well.
Oh, interesting.
Right. So it's not completely about, financial resources is one factor, right? So rich people or rich immigrants may not experience this downward in neighborhood, right? So in terms of neighborhood alienation, neighborhood disorder may not be reason, but neighborhood alienation may be still a factor, right? So thinking about when immigrants, most time they come here for job, most time they hang out with people in their workplace, right? And once we have they probably do not have a job anymore. Then they need to stay in that neighborhood, right? And when they have work, they don't spend in neighborhood much. So that's why this neighborhood alienation can increase in later life, because once they have to stay in that neighborhood for most of the time, they find out they are actually not quite part of it. Right? So this neighborhood alienation can increase no matter what's their CS status.
Interesting. Just what, sorry, what, so what would be your policy recommendation for?
Oh, it's well, that is a policy sentence.
Yeah, because I'm a professor of public policy. I need to know.
Yeah, I think so. I think we really need to think of some factors buffer the retirement effect, including the social support and including for poor immigrants or financial resources. But this a community engagement is one factor that is doable, right? It's policy doable. That is include kind of improving older immigrants kind of community engagement, but that can potentially reduce the neighborhood alienation later on.
Sounds really good. Okay, one more last question.
I was just going to say, like, I, one of the things I do is quite a lot of qualitative research, and in the qualitative sphere, I've heard many times the kind of story of like, once you get older, you want to return home, but your children are now in the country where you immigrated, and so you had a plan to go back, but you can't go back because you want to be.
You
near
don't
your
have a
kids.
home in your home country.
Exactly, and so
And,
you end up in this funny in between place in your old age which you didn't expect. And again, this is just from qualitative interviews
Yeah.
I've done, but I've definitely heard this story before.
Yeah, so they cannot to return to their home country, and they also feel more alienated in the neighborhoods.
Yeah.
So, and also most time maybe kids are also not nearby, right?
Yeah.
Because the immigrant children are always cheap. So they may move to our place, they probably do not live in the same city.
But that might be the case.
Yeah.
Great. And I think our time is up. Well, thank you very much. And thank you everybody for listening and for your feedback and questions. Just wanted to mention our next speaker series is on April 3rd. 17th, sorry, April 17th. And Alexa Carson will be talking about care and toward the older people amongst immigrant communities. So do come and join us for that talk as well. Okay, thank you.